right, on this slide, we are going to be looking at the iliopsoas, which is going to be comprised of 2 or 3 muscles. We're looking at the psoas major, psoas minor, and iliacus. Major is the most important of the major and the minor, but the iliacus is as important as the major of the psoas. So let's look at our 3D illustration here. I'm going to go ahead and turn off the rectus abdominis. That's on the anterior aspect, and let's go ahead and hide the linea alba as well. All right, so we can see here that we have psoas major, minor would be in the relatively the same spot, and the iliacus. All right, so let's just go ahead and isolate the psoas major. We can tell that the psoas major comes off the vertebral bodies and the transverse processes in the lumbar region, and it also comes down and attaches on the lesser trochanter. Now, if we use our line of pull, we can tell that we would be able to possibly do a lateral flexion to the same side, or what we may also hear a term of ipsilateral rotation, or I'm sorry, ipsilateral to the same side, or contralateral, meaning to the opposite side. So let me clarify, make sure we get that right. Ipsilateral means to the same side, contralateral means to the opposite side. So in this situation, we would laterally or ipsilaterally flex to the same side, right? All right. With our sternocleidomastoid, we were to think about it, we might contralaterally rotate it to the opposite side. So that would be contralateral example. All right. So we could flex to the same side, or ipsilateral flex to the same side. We could also flex the vertebral column. We could also flex at the coxal joint, right? So there's 2 different flexes that could be happening here. We could flex at the coxal joint, and we may also flex at the trunk by all of the facet joints up in our lower lumbar region of our illustration here. Could we also do some sort of rotation to the femur? Would it be lateral or medial, or external or internal rotation? It would be lateral rotation. At the coxal joint as well. But what's really important that we want to think about is what would happen if this musculature was really tight. We know that this type of a curve that we're looking at here in the lumbar part of our spine is a lordotic curve. If this musculature becomes very, very tight, it can make it even more excessively a lordotic curve, which could put tension on that lower back, which once again could affect the SI joint right in this area here, as well as the nutation or counter nutation in this example, for it to be an anterior tip pelvic, or to bring that whole pelvic region anteriorly. All right, so once again, action wise, it's going to flex at the coxal joint, it is going to laterally rotate at the coxal joint, and it's also going to flex the lumbar vertebral column. All right, if we were to go back, we can look that our iliacus is attaching in the same spot insertion wise, but it's originating on that iliac fossa, right, in that smooth part where the iliacus attaches, performs the same type of action. Only true really difference is it doesn't go up and attach onto the column of the spine, the lumbar region, so it's not going to aid in excessive lordosis, if you will, for that musculature. But it will also pull that pelvis forward, or anteriorly tilt that pelvis if it were taut. And we think about, with our sedentary lifestyles today, we are seated in the seated position a lot of the time, so these 2 muscles specifically could be really shortened, as well as our hamstrings possibly, from being seated at a desk or driving a lot. Maybe we do insurance or real estate, or we're a student, or whatever it might be. Sedentary lifestyles, lower back issues, really prominent. All right, thank you. That is the iliopsoas for this slide.